We're live.
Yes, sir.
So should I share my screen? Is it okay?
Yes,
Hello.
sir. Yes, sir.
Okay.
Hello, this is absolutely fine.
Okay.
Okay, I'll introduce you and then I'll hand it over to you, sir.
Sure.
Uh, a very good evening to one and all. Let me extend a warm welcome from the House of Lupin, the makers of Easy Flow and Deskcast. At Lupin, we salute the gesture of our healthcare professional who have been the frontline warrior in this war of COVID-19. In this difficult times of COVID-19, definitely we have got an opportunity to disseminate knowledge through e-platform. And to do the honors today, we have Dr. Angshuman Mukherjee, a very eminent and audacious speaker from Kolkata, who's going to speak on COPD and cardiovascular comorbidities, consideration for clinical practice. But before we move on to the topic, let me take this privilege to introduce Dr. Angshuman Mukherjee. As I've already said that Dr. Angshuman Mukherjee is one audacious speaker. He shares his vivid and enriched experience. Dr. Angshuman Mukherjee is a consultant chest physician in Department of Pulmonary Medicine at Fortis Hospital. Dr. Mukherjee has completed his MD Pulmonary Medicine from Medical College, Kolkata, and then went on to do his diploma in Respiratory Medicine, Amsterdam. Dr. Mukherjee has special interest in EBUS, allergy, severe asthma, sleep disorders, and ILDs. Besides that, Dr. Mukherjee is member of all eminent bodies like ERS, NCCP, ICS, Association of Chest Physicians of West Bengal. Not only that, he's been awarded as Best Student Award in Pulmonary Medicine from Medical College, Kolkata in the year 2030. He's been delegate to several national and international conferences. So, without any further delays, I would like to hand over the session to Dr. Angshuman.
Hello.
Hello.
Good evening. Good evening. I'm Dr. Angshuman Mukherjee. Paulash has already introduced me, so nothing more to tell about my work and everything. So I'm Dr. Angshuman Mukherjee working at Fortis Hospital. Just a moment. Okay. So I would be talking on COPD and cardiovascular comorbidities and consideration for clinical practice. This is one of the very hot topic in today's era. And you know, as we are going through a COVID phase, COVID era, COPD and COVID, the ratio, the togetherness of COPD patients with COVID, we are facing a lot of problems with this sort of diseases actually. So we have to know about this COPD and cardiovascular comorbidities in this COVID era also. So when Gold 2020 defined COPD, they defined it as persistent respiratory symptoms and airflow limitation. These are the two important words they have shared with us. You know, this is common, preventable and treatable disease, but these two important phrases are things that Gold has told us about COPD definition. Now, if you see the chronic airflow limitation, which is actually a characteristic features of COPD, that is actually caused by small airways disease and parenchymal destruction, which is known as emphysema. So we have already known that COPD is a small airways disease, and emphysema, that is parenchymal destruction. So that is the main features of COPD. What about the burden of COPD? And if you see this picture, this slide, from 1990 onwards to 2016, we have got a phenomenal increase in COPD rate. We have got almost 50% increase in total case number, whereas an increase in prevalence from 3.3 to 4.2%, which is quite significant back in year 2016. So I don't have exact data of 2020, but if you see the data of 2016, which is quite horrible. In India, 3 out of 5 leading causes of mortalities constitute the non-communicable disease, whereas COPD stands second. So that is worrisome. 2 pictures you have in your screen. One is slightly pale picture, that is of 1990, probably a better picture when we had COPD mostly in our north and middle part of our country, also some part of our south. Now, if you see the picture in 2016, you see most of them are red or say brown color, which actually signifies that the prevalence has increased more than 4,000 patients per 1 lakh population. So 29.2% increase in crude prevalence actually. About exacerbation, I will not bore you with this definition of COPD exacerbation, but it has got a characteristic features of worsening the lung function. It has got symptoms like cough, dyspnea, and sputum, our forefathers' Anthonysen's criteria, and increased airway inflammation and systemic inflammation is one of the cornerstone of COPD exacerbations. So today, when we will be talking next 20 minutes odd, so we will be talking mostly about the exacerbations, about the inflammation, their effect on cardiovascular system, vice versa, and one special drug, that is Salmeterol Fluticasone. The role of inflammation, you all know that COPD is a disease of inflammation, and the exacerbation is another major outbreak in the inflammatory pathway. Eosinophils are increased in the airways, lung, blood in a significant proportion of COPD patients. I will show you in graphs. Furthermore, the number of eosinophils increase together with neutrophils and other inflammatory exudates during exacerbations. This is one of the biologic phenotypes of COPD exacerbation, and you can see 4 dots, 4 colors. The blue one is bacterial predominant, the red one is viral predominant, the green one is eosinophil predominant, and the another one is post-inflammatory. What about cardiopulmonary involvement in COPD? In a single nutshell, we can tell it as cardiopulmonary continuum. The COPD patients, cardiovascular comorbidities are highly prevalent and associated with considerable morbidity and mortality. So this coincidence of COPD and cardiovascular mortality or morbidity together is known as cardiopulmonary continuum, rather than being simply attributed to a shared risk factor such as cigarette smoking only. This is a fantastic picture, and the center of the picture is inflammation. So inflammation in either way to these systems or the phenomena like metabolic events, psychiatric events, cardiovascular, musculoskeletal, it can damage all these organs or all these systems. Vice versa, damage of these organs or systems can also lead to major inflammation. The cornerstone, or rather the future of inflammation, is actually in both the organs, lungs and heart, in 2 forms. So in heart, they causes atherosclerosis, which ultimately, by virtue of remodeling, leads to organ failure, that is heart failure. Whereas obstructive bronchitis is caused in lungs, which ultimately lead to exacerbation followed by emphysema and respiratory failure. So heart failure and respiratory failure is the end point of this whole picture, leading to severe organ failure in COPD and cardiovascular events. Again, a fantastic picture if you see the insults like smoking, physical inactivity, poor diet, air pollution, etc. This ultimately leads to inflammation and accelerated aging, remodeling. So inflammation by the pathway of TNF-alpha, by interleukin 6, CRP, fibrinogen, etc. An accelerated aging process, that is like telomere shortening, cellular senescence, reduced cell proliferation, etc. These are complicated microbiological process. So ultimately leading to COPD and cardiovascular morbidity or mortality, whatever. The basic pathway leads to hypoxia, hypercapnia, and vessel wall abnormalities, which ultimately ending to oxidative stress, atherosclerosis, and most importantly, endothelial dysfunction, which ultimately leads to cardiovascular diseases. So if we use bronchodilators like LABA, LAMA, ICS, etc., this can reduce the COPD, reduce the respiratory inflammations, which ultimately benefits the cardiovascular morbidity. Whereas if you use several cardiovascular medications like statins or ACE inhibitors or antiplatelets, that ultimately helps in respiratory problems. So how COPD presents, you all know. I'm not going through the details, but smoking and COPD and cardiovascular disease, they are particularly closely linked. So when we are talking about COPD and cardiovascular comorbidities, there are increased risk in both the cases. There are increased risk in acute exacerbation of COPD, as well as increased risk in IHD and heart failure, that is most commonly observed cardiovascular events in COPD patients. So here is another picture. You can see the hazard ratio of COPD in different heart diseases. And if you find out, if you see in your picture, if it is clear enough, you can see that ischemic heart disease and pulmonary artery hypertension is one of two of the major things happening over here. This is a good picture. This is a fantastic picture which showing that COPD and cardiovascular disease, the clinical coexistence between these two diseases, and both the disease can coexist into one another. Cardiovascular comorbid illness in COPD patients. What about the Indian data? So India witnesses a very high incidence of comorbid illness in COPD patients, and as per the survey among doctors, you can see 78% of doctors say 1 out of 4 COPD patients have got congestive cardiac failure. Even we in our hospital, we see a lot of patients coming with congestive cardiac failure, with raised NT-proBNP, with echocardiographic abnormality in patients with COPD. Whereas 40% of doctors say 1 out of 2 COPD patients have got comorbid coronary heart disease. So that is the prevalence of cardiovascular events. So I have already told hypertension, IHD, heart failure, you can see in this graphical representation, these are the major effects of cardiovascular morbidities happening in patients with COPD. COPD assessment goals, the major goal is to reduce the future events like exacerbation and hospitalization. And what are the way of achieving these goals? The way is to get a proper spirometry done, spirometric analysis to rule out any spirometric abnormality, the current nature and magnitude of the patient's symptoms, history of moderate and severe exacerbation and hospitalization, and presence of comorbidities. These 4 things we need to assess. You all know about this group A, B, C, D formula. I'm not going through this in detail, but the main treatment goal is reduction of symptoms and future risk of exacerbations. And one of the most important tool in our hand is inhaled corticosteroid plus long-acting beta agonists, so ICS-LAVA combinations. So same thing, I'm not going through detail. The suppression of the inflammatory response is one of the most logical approach to the treatment of COPD to reduce the cardiovascular comorbidities. So now coming to the effect of inhaled corticosteroids on exacerbation reduction rate. So if you see, I'll come with a picture. If you see the blood eosinophil level, so here it is, more the blood, this picture, more the blood eosinophil levels, more the inflammation. And if you use ICS, inhaled corticosteroid, here in the form of fluticasone along with vilanterol, if you see that vilanterol alone, so the green bar is vilanterol alone, even here also, and the blue bar is fluticasone plus vilanterol. So in annual exacerbation rate, as well as so in the annual exacerbation rate, it is quite lower in patients using fluticasone plus vilanterol when compared to vilanterol alone. So ICS actually reduces the blood eosinophil and helps in reducing the exacerbation rate. Here is also, if you use indacaterol glycopyrronium in comparison with, this is another fantastic drug, compare with salmeterol fluticasone, you see when the eosinophil count is between 0 to 300, so the first 2 diagrams, the reduction of eosinophil counts or reduction of annual rate of exacerbation is quite high when we are using indacaterol glycopyrronium rather than salmeterol fluticasone. But when it is more than 300, salmeterol fluticasone improves the eosinophilia is improved by salmeterol fluticasone a lot, as well as the inflammation. So, in a nutshell, patients with one exacerbation per year and a peripheral blood level of more than 300 eosinophils per microliter, they are more likely to respond to ICS-LAVA treatment. Whereas patients having more than 2 moderate exacerbations per year or at least one very severe exacerbation prior year, they have got ICS-LAVA treatment considered at blood eosinophil count more than 100 per 100 cells per microliter. One of the fantastic study, one of the milestone study, 2007 TOT study, ICS-LAVA can be effective in preventing exacerbation. Once you can prevent exacerbation, you can prevent inflammation also. And here you can see all the moderate to severe exacerbation, the patients who are requiring small dose of corticosteroid, so small corticosteroid dosage, and the patient requiring hospitalization, everything is quite reduced, significantly reduced when using salmeterol and fluticasone in a combination rather than alone. Another picture where you can show, you can see airway inflammation increases as COPD progresses. I've talked it in my earlier slides, not going through detail. This is one of the important slides. Myocardial infarction rate increases with COPD exacerbation frequency. So the more the exacerbation, say if the exacerbation is in the form of 3, 4 or more than 5 per year, you can see a very high mortality rate or very high rate of myocardial infarction per 100 patients per year. What about salmeterol fluticasone combination? Why we are talking about salmeterol fluticasone? Because fluticasone is a very potent ICS. It has got a high lipophilicity and it has got a longer duration of action. And when combined with salmeterol, it has got very high selectivity in terms of bronchodilation without any cardiac acceleration, and it has also got a longer duration of action. So that is the main aim of giving salmeterol fluticasone. So need not to be talked that salmeterol is a very high selective beta 2 agonist. What about anti-inflammatory effects of salmeterol fluticasone? Several studies shows that it reduced the CD8 cytotoxic T lymphocytes and CD68 plus macrophages, cells that have been shown to be correlated with COPD disease severity and recognized to be important in the pathogenesis of COPD. So SFC has an airway anti-inflammatory effect not seen with inhaled corticosteroid alone. Again, just talking about another drug, indacaterol glycopyridinium. So you know, indacaterol glycopyridinium has got a very significantly improved lung function when they are using when we are using indacaterol glycopyridinium up to 26 weeks compared to the monocomponents or the tiotropium. So the phenomenal flame study, it shows the indacaterol glycopyridinium also significantly reduced the rate of moderate to severe exacerbation versus salmeterol fluticasone over 52 weeks. So there is significant reduction, 17% reduction of exacerbations per year. The trough FEV1 also increases up to 62 ml, which is quite high in patients having moderate to severe COPD. And if you see the adjusted mean SGRQ total score, that is also improved in patients with indacaterol glycopyridinium. So what about again back to salmeterol fluticasone, what about the clinical evidence of demonstrating the cardiac safety of salmeterol fluticasone? And there is a huge study containing almost 12,200 patients, a meta-analysis of 24 randomized double-blind parallel group placebo-controlled study where patients received inhaled LABA, and there are almost 7,800 patients who received placebo therapy. And what is the effect? It shows that in a subgroup analysis, the inhaled LABA is significantly decreased the fatal cardiovascular events in long-term trials and in trials with severe COPD patients. And among the different type of LABA, salmeterol has got a significant effect. Another study which showed that there is no increase in cardiovascular acute exacerbation risk in COPD patient compared with placebo versus salmeterol fluticasone. Cardiovascular events in patients with COPD, the TORT study, I'm not going through detail, already told you about TORT study, but if you see this graph, the cardiovascular acute event is lowest for salmeterol fluticasone at 11.3% when compared to the mono agents like fluticasone alone, salmeterol alone, or placebo. Even this study, this graph also showed that cardiovascular event, the probability of cardiovascular acute event in 3 years is least for salmeterol fluticasone, and the probability of cardiovascular severe acute events by 3 years is also least by salmeterol fluticasone. What about the cardiovascular events in patients with COPD, the TORT study? Again, the conclusion is salmeterol is not so harmful for cardiovascular health as known previously. About the clinical evidence of improvement in cardiovascular outcomes by SFC. So another important study back in 2011, the evidence is increased arterial stiffness may mediate part of the increased cardiovascular risk associated with impaired lung function. It was a multi-center randomized double-blind study which concludes that SFC does not reduce the arterial wave velocity, the aortic pulse wave velocity in all patients with moderate to severe COPD, but may have effects in those with elevated arterial stiffness. So that was the conclusion. About the clinical evidence demonstrating improvement in exacerbations. This is very significant. The effect of fluticasone propionate and salmeterol combinations or the salmeterol alone on COPD exacerbation. Nearly 700 patients were there, and the result showed that SFC significantly lowered the risk of experiencing recurrent exacerbation by 25% compared with salmeterol. That is also shown by the TORT study itself. So SFC delays the first exacerbation, no doubt. And SFC also, if you see the cumulative proportion of free of exacerbation, the mean time to first exacerbation rate, that was 128 days versus 93 days between SFC and salmeterol alone. There is also significant improvement when it is compared between SFC and salmeterol alone, that 41% patients showed clinically meaningful improvement of SGRQ score versus 30% in salmeterol alone. So that is significant. About the impact of salmeterol fluticasone propionate versus salmeterol on exacerbation in severe chronic obstructive pulmonary disease, the conclusion is SFC significantly reduces the frequency of moderate to severe exacerbations in severe COPD patients. About the prevention of COPD exacerbation, SFC or tiotropium bromide, important one. So the result is probability of withdrawing from the study was 29% greater with tiotropium than SFC. The modeled annual exacerbation rate, modeled annual exacerbation rate was 1.28 in the SFC group and 1.32 in tiotropium group. So the total SGRQ was significantly lower in the SFC group compared with the tiotropium. The proportion of patients achieving a clinically significant improvement in SGRQ at 2 years was greater in SFC, that is 32%, versus tiotropium, that is 27%. So to conclude, a small statistically significant beneficial effect was found on health status with lower deaths in SFC treated patients. So COPD often exists with other disease known as comorbidities, you all know, that may have significant impact on disease course. And among these comorbidities, the important is the cardiopulmonary continuum. Prevention of both exacerbation as well as comorbidities is the key component of the treatment strategies for COPD. And cardiovascular death or cardiovascular disease presence is associated with increased risk of hospitalization, longer length of stay, and all causes CVD related mortality. So ultimately, you have to reduce the inflammation to control the cardiovascular events in patients with COPD. So both COPD and cardiovascular diseases are centrally linked to systemic inflammation. I've already shown you. And SFC salmeterol fluticasone has a broad spectrum of anti-inflammatory effects in COPD that I have shown you in different parameters. Previous studies have shown that SFC can reduce the levels of inflammatory factors. Previous studies have shown that SFC can reduce the levels of inflammatory factors and improve the symptoms of COPD also. The cardiovascular safety of salmeterol has been established. In addition, a post-hoc analysis of cardiovascular events in TORCH study suggested that LABA-ICS combination in the form of SFC may be cardioprotective. So that's
Hello. Hello.
hello.
Yeah, sir, we will open it up for the questions. While Shomak is handling that.
Yeah,
link.
Sure. Actually, sir, this is a very nice session or a very elaborative and a very nice session by you, sir. So some questions what I have noted, that one from the Patna region is that is there any better choice like salmeterol fluticasone in elderly comorbid conditions, by Dr. Jiram Prasad?
So Dr. Prasad, good evening. I've already told you that indicatral glycopyridinium is one of our important choice, which has got slightly a better foot forward in terms of reducing the exacerbation and reducing the cardiovascular comorbidities, and you definitely you can use it in your elderly patients. So indicatral glycopyridinium is an option. The indicatral glycopyridinium along with some ICS, which is a forthcoming drug, is probably another option. So while you are using SFC, salmeterol fluticasone, that is okay. If you want to use something else, I would suggest indicatral glycopyridinium. That's it.
Fine, thank you, sir. And
sir, I have received one question from Dr. Nadipati Ramakrishna from Bhimavaram.
Right.
He's asking what is the role of C-reactive proteins attributing to COPD inflammation, and how to monitor that.
So, hello, doctor. That's a very good question. I've seen different phases of COPD exacerbations, and if you see different phenotypes or different biotypes of COPD exacerbations, one is bacterial infection. So we receive several COPD patients who has got bacterial infections and who come to our hospital in a bad condition. In those patients, if you monitor CRP along with total count and differential count, you will get an idea whether you are going through a right pathway in terms of giving antibiotics. If the CRP is rising, you can change your antibiotic. Presumptively, you need not to go for a sputum CS. Definitely a sputum CS is required or a BAL CS is required, but until the BAL CS report comes, you need not to just rely on the BAL CS report or the sputum CS report, but seeing the CRP only, or the TC and CRP, the variation, the change in TC and CRP, you can directly go for an antibiotic change. So that is one important area. Any question else?
Thank you. Thank you very much, sir. Thank you very much.
yeah, sir, another very interesting question came from the Bardhaman region by Dr. Shyam Agarwal, that he just asks us that in controlling inflammation for the COPD patients, would you choice that the fluticasone is a better choice than any other ICS available now in the Indian context?
So in Indian context, I guess both fluticasone and budesonide, they are doing head to head. So budesonide, my personal opinion, rather my personal choice is I always prefer to use formoterol budesonide, but not like Salmeterol is also a very good drug. Salmeterol along with fluticasone combination is also a very good drug, and fluticasone is far more potent steroid. So you can definitely use fluticasone. If you want to use something else, you can go for formoterol budesonide.
Fine. Thank you, sir. Another one question is came from the Dr. Patel is that he asks that in the long-term maintenance for the COPD patient, what you recommend? In this case, salmeterol fluticasone, how could you place this particular drug?
That's a very good question. That's probably the best question I have received. So, what you can do is, in case of COPD long-term maintenance, you have to tick few boxes. Number one, bronchodilation. When we are talking about bronchodilation, in my book, the first preference is ultra long-acting LAMA, that is indacaterol glycopyrronium. If the patient cannot afford financially, I would then go for either formoterol budesonide or salmeterol fluticasone, whatever. No particular choice. Next is, I would definitely add one LAMA in the form of tiotropium. If not, I am giving indacaterol glycopyrronium. Is that clear?
Fine, sir.
Next is, definitely I would go for mucus clearance, either in the form of N-acetylcysteine or in the form of some respiratory physiotherapy, whatever. I would go for vaccination of the patients. I would go for physical rehabilitation of the patient. It's not like physical rehabilitation means you have to go to the gym, you have to go for some big exercise like that, but I would definitely ask the patient to walk for 20 minutes every day and to do some free hand exercise and breathing exercise. So these 3 or 4 things are very important. Avoid cold, avoid dust. These are definitely important. Avoid smoking, quit smoking. That is another important area. Vaccination, you must not forget about vaccination. So both the pneumonia and influenza vaccines you have to add on. So these are the things in long term I would consider for my patients.
So thanks a lot for your question, sir. Yeah.
Hello.
Hello.
There's one more question from Dr. K. Yadav from Darbhanga. He's asking what is the role of roflumilast and macrolide group antibiotic in a patient with COPD having more than 300 eosinophil counts?
Another very good question. So macrolides in the form of either azithromycin or clarithromycin, you can use. We often use macrolides in the form of azithromycin in patients with COPD. There are certain dose factors in dosing. So the doctor who is asking question, he definitely knows about this. What I make is, when the patient is having eosinophilic pneumonia or eosinophilic exacerbation, macrolide is one of the good ones. Other cases, you can use roflumilast, but mind few things. So either you use roflumilast or you use things like theophylline. So either theophylline or roflumilast, any of the two you can choose. In patients having chronic bronchitis phenotype who are producing no flames, who are slightly obese, in those patients you can use roflumilast. Data shows it has got a important role in the COPD in reducing the morbidity and mortality in COPD as well as the exacerbation rate. So that is one important area you need to understand. Next is about roflumilast, macrolides, anything else? Yes.
Oh, roflumilast and macrolides, yes.
So yes, so you can use macrolides like azithromycin 250 milligram twice weekly. Gold has recommended even daily, but you need to do you need to do a ECG on a regular interval. So that is how I prefer to use in an alternate day fashion. So you can use your macrolides and you can follow up your patients for next 1 year. I used to give for 6 weeks to 3 months first, and once the patient is stable, I used to continue for 1 year even.
I think I've done with the questions from my end. I think Shomak, do you have any questions from your end?
No, sir. No, sir. Till now, the questions what we have, the good questions what we have right now that I have already discussed with sir also.
Okay.
So I take this opportunity to thank Dr. Angshuman. I think it was one heck of a presentation. It was very, very informative. And I also take this opportunity to thank the doctors from Pan India who have taken time to join on time. And I'm sure they've got a lot of information in terms of how to approach COPD patients with comorbidities, cardiac comorbidities. And I'm thankful to Dr. Angshuman that he was patient enough and very rightly and nicely explained all the questions, all the queries. Thank you. Thanks a lot, sir.
Thank you.
Thanks a lot, sir. Thank
Good
you,
night.
sir.
Thank you very much. Have a nice evening, sir.
Thank you.